one of the things I'm really excited about is having you and your friend, Dr. Brian Kennedy, on stage talking about this lineage 2
Yeah. Yeah.
biological age clock.
So again, that's an interesting case example where I would say lineage two. So first of all, this phrase biological age clock is tricky, right? Lineage two doesn't measure biological aging. It's a mortality estimator, right? So it's trained on your risk of dying, which is correlated to biological age. I know it gets super complicated, but it doesn't measure biological age. Some people even argue biological age, because it's a multidimensional feature, like I was saying, is what's called a latent variable that can't be measured. So that's a different conversation, but nothing measures biological age today. Lineage 2 is super interesting, though, because the components that are used to estimate your mortality risk are all well characterized clinical parameters like insulin levels, glucose levels, lipid levels, things that we understand both what the error rate of the measurement is and why those things are connected to mortality in many cases. But what lineage can do for you is it can tell you, and these are the 5 parameters that are driving that mortality prediction. So if we lower your fasting glucose, that will have a positive impact on your mortality risk estimate. And so that's the thing we need to focus on. So that's very different from these epigenetic tests, which, first of all, the number means nothing statistically, but they don't even tell you what to do about it. Whereas lineage at least gives you some actionable metrics that you can go after to try to reduce your predicted mortality risk. And you'll note I'm being very careful in saying it's your predicted mortality risk. We don't actually know it's your true mortality risk. That's the other thing people need to appreciate with these
And these are all
tools.
biomarkers that we should have, our doctor should have on us, or hopefully we do have. So that's exciting.
Yeah, I mean, mostly. So yes, you're right. We all should have them. Most people don't because again, our reactive disease care system isn't designed to capture the most relevant data on most people. It's a couple $100. So it's not, it's not dirt cheap, but it's not out of reach, I think, for most people. And it's certainly not out of reach if we as a society, or let's just say Oklahoma City, made the decision, or Oklahoma State, that everybody is going to get this baseline core set of biomarkers. It's not out of the realm of possibility for that to be affordable. If we allocated $5,000 per person to this, we could get those lost decades back. I'm just going to put that out there. That's not an unreasonable amount to spend when you think of what we're spending on health insurance. We will more than recoup that in savings for healthcare costs if we were to do this.